So the participants are not shown?
No, it is not shown. Okay.
All right.
So
So how can I get their questions
I
then if they have?
no, the questions will come if they come.
All right. Okay. All right. Okay.
Uh, Welcome, dear colleagues and friends and young intensivists. Today's session is on helmet ventilation. So helmet ventilation, we have all been using NIV and invasive ventilation. Most ICUs now have high flow also, but helmet is something we don't really use. One of the problems being that evidence is not very strongly there in favor of helmet ventilation. Nonetheless, it is a useful device and one must know how to use it, and it has its own advantages. That will be discussed by Dr. Ranajit Chatterjee, sir. So, sir is eminent personality in our critical care arena. Sir is the head of critical care and emergency at Swami Dayanand Hospital, New Delhi. So, without further ado, I will hand it over to Dr. Chatterjee.
Thank you so much, Dr. Tapesh. And I first of all congratulate you to continue relentlessly such a beautiful educational program, which is helping, I think, lots of intensivists all over India and also outside India also. And I have seen you toiling for this for the years, and now you have become a known face amongst all the budding intensivists. Congratulations to you, and please continue the good work that you are
Thank you,
doing.
Dr. Chatterjee. Thanks to you, to people like you, to all our senior faculty who have been taking regularly, selflessly, finding time, making presentations. And definitely our students have found it very useful. Feedback is very encouraging. That helps us to go on and on and on, because there is a lacuna of proper, resource material for learning in our country, I think, and for the young
Yes.
across the globe.
Yes. So, and you are calling the right persons in the right time, because it is always better to share our knowledge, which we are doing ourselves, rather than sharing the theoretical knowledge, which can be gained anytime, anywhere. So today I am going to speak on, I can see that two eminent persons have joined already, Tapush, before I should start. Dr. Sharmili Shina, she is the EC member and senior consultant and head of Apollo Intensive Care. She has joined. I'm honored. Dr. P.K. Das has joined from RML Lucknow. They're all my good friends. I've just sent it to them and they're joining. Monalisha Mishra, I think she has joined from Bhubaneswar, if I'm not wrong. And so that's a great thing that they can also share if they want their own experiences, because they are very eminent persons.
Yeah.
So
it does not show the complete viewership. You have an audience of 200, I can see.
I know that, but the persons who have joined with us are that I'm telling you that they're so I know them, so I thought that I should introduce them. So without wasting any time, let me start. And so I first of all salute all those heroes during the COVID times whom we have lost, our friends, our colleagues, our seniors, our juniors, the medical fraternity, and also the nursing personnel. Everybody actually toiled like anything. They got the infection directly from the persons, and mainly during the time when they are using non-invasive ventilation with the help of a face mask. In fact, with the help of with non-invasive ventilation with face mask became basically the harbinger of spread of this COVID infection amongst healthcare personnel, and we helplessly saw our personnel getting affected, and we couldn't do anything because we are not having helmet regularly with us, neither we are having the experience with using helmets. Till now in India, very few centers are using this interface regularly. I'm fortunate that I'm using it for the 8-9 years. I got, first of all, imported it from Italy, and now it is a regular affair in my ICU, and I find it quite easy to use, and I can share my experience with you, and that is the reason I am here today. And as you know that I don't have any disclosures to make, and it's completely a philanthropic exercise. Now, nobody, whether it is a patient or a doctor, will want that they go into the situation of intubating patients. The moment you declare that I'm going to intubate my patient, it becomes a uh, very pathetic affair basically uh, for the patients, for the doctors, everyone. The doctors basically they will try to they know that once we intubate, I have to also take the patient out of the ventilator to wean the patient. It's a mammoth task. So if I can manage my patients on non-invasive ventilation, it really might help us uh, in avoiding many complications of mechanical ventilation. So basically, we are augmenting the mechanical ventilation, our spontaneous ventilation, without the aid of endotracheal intubation. This is the simplest possible form of description that we give to non-invasive ventilation. So uh, these were the negative pressure NIVs that were used in the yesteryear, especially during the polio epidemic. These were known as iron lung, and there we used to give negative pressure ventilation to the patient. But now we have moved on to the positive pressure ventilation. We all know very quickly the advantages. As we all know, it is a non-invasiveness. Naturally, the flexibility in initiating and removing mechanical ventilation. It also allows you intermittent application, improves patient's comfort, reduces the need of sedation. There is oral patency, there is pressure of speech, swallowing, and expectoration, and reduces the need of nasogastric tubes. These are the basic advantages. It avoid resistive work imposed by the endotracheal tube, avoid complications of the endotracheal tube intubation. It may be early complications like local trauma, aspiration, hypotension, or it may be a late one, that is injury of the hypopharynx, larynx, trachea, ventilator-associated lung injury, hospital-acquired pneumonia, reduces infection complications like hospital-acquired pneumonia, ventilator-associated pneumonia, sinusitis, sepsis, etc. And obviously, it is much less costly than that of its invasive counterpart. So, in order to make the non-invasive ventilation successful, we need a good interface. Either it may be a face mask, or it may be a full face mask, it may be a nasal mask, or obviously the helmet. Now, if you see the face mask, which is the most commonly used interface, you know during COVID times, the intensivists were not present. In most of they were lacking because the number of intensivists were less and number of patients were huge. So mainly this the non-invasive ventilation was managed mainly by the paramedics or just maybe a much more junior staffs who are not very much conversant with non-invasive ventilation. We think NIV, though it has become BiPAP has become a household name today, if we are not experienced enough to use a BiPAP, if we don't know exactly the settings that you have to give in a BiPAP, my machine may deteriorate and might kill my patient. So it is so important to know about the BiPAP settings. However, today it is not the day of settings. I will only go to use helmet properly. So at least the basics one that should be told. For example, the vented versus the non-vented mask. I went to one of the conferences this time in a physicians conference. When I showed them the mask, many of them were clueless exactly what is a vented and what is a non-vented mask. That means during the COVID times, many of the patients were used the wrong mask during the wrong type of machines to be used. For example, if you're using a single tube machine like a BiPAP machine, then you should have a vented mask so that the carbon dioxide can come out through those vents. But if you're using a double tube, that for example you're using a mechanical ventilator to give the non-invasive ventilation, that is a double tubing system, there you don't need a ventilation. So these are the basic things that were missing during the COVID times, not only in India but also all over the world. So face masks has been used extensively. We should know where exactly to use the vented mask, where exactly to use the non-vented mask. As I told you, if you have a single tube, use the vented mask. If you have a double tube, use the non-vented mask. But face mask has its own problems. See the eyes of this girl who is on the face mask, how claustrophobic it is. If you can put the mask on yourself, you will understand how claustrophobic the face mask sometimes becomes. Though I am telling that we can cough, we can swallow, if you put a face mask, it's very difficult to cough out. You can't speak, you can't swallow properly. And above all, if you have a nasogastric tube inside, definitely it will not fit in properly. You have a lot of leaks. And the most difficult part is that after a day or two, you start developing ulcers over the skin, the rashes, ulcers. It's so painful. And the patient becomes so irritable that slowly we have an NIV failure of 18 to 40%. So it causes skin irritation, sore nose, air leaks, stomach bloating, chest or lung pain, dry mouth, nasal congestion, eye irritation, claustrophobia, and what not. And that is the reason of the failure of non-invasive ventilation most of the time, because of the non-compliance of the interface that the patient faces when they are using this face mask. And also, there are only three sizes of face mask. How it can be the surrogate of the billions of population all over the world? So, does the face of Amir Khan match with that of Amitabh Bachchan, with myself, or with the very interest lady? It's not possible. Every face is different. And if the shape of the face is different, how can a three size mask fit the face of these people? The A mask which is fitting to Mr. Bachchan might not be fitting to me. Now be fitting to this edentulous patient, not be to the Amir Khan, who is bearded here. So that is the main problem of our faces of the face mask, which is basically not in different sizes, but not in that particular shape of that person. So it cannot mold the mask into the person's facial structure, and that is one of the reasons why it leaks, and it sometimes causes a lot of pressure. Obviously claustrophobia and other problems are already there. So what can we do? How can we basically avoid this problem while you are using the face mask? We have a different type of interface? So the answer is yes, we can have a helmet. So helmet basically give you a better tolerance. It can be used for a longer duration. There is more patient autonomy here. Patient can look around, speak, drink, eat, cough, wear glasses, read, etc. They can do everything with the help of with the help of the helmet. You can also open the helmet. You can allow the patient to drink, and again you can close it, and the helmet will just take its own shape and continue the ventilation. The air leaks are rare. One of the main problems with face mask is the air leak. Doesn't fit properly. Either it is too tightly fitted or too loosely fitted. The moment it becomes loosely fitted, there is air leaks. Moment there is air leak, the pressure doesn't develop, and obviously our aim of non-invasive ventilation fails. And there are no skin lesions here in the helmet. It sometimes may be claustrophobic, relatively claustrophobic, but a good assurance, if you can put the helmet on yourself and show it to the patient and then put it on the patient gets reassured, and obviously that claustrophobia part goes off. But there are definitely certain disadvantages. It is a very big space. So that causes a lot of patient ventilator asynchrony. Due to this big space, there is CO2 rebreathing and a lot of noise. If you're using non-invasive ventilation with the helmet, you'll find a lot of noise is created by the helmet. And that is very disturbing for the patient. We might tolerate it because there are so many sounds in the ICU. The doctors or the nurses might tolerate it, but for the patients, so that's especially that patient who is on which the patient on whom the helmet has been used is being used, the patient becomes very much intolerable with that noise. So how we can overcome these disadvantages and use the helmet properly, that is basically the aim of this lecture today. So when the helmet started coming, so it started in the first one of the first papers here in intensive care medicine. It came out in 2003. A helmet has been very popular in Italy, and this time also in COVID times also they have been very widely used in France and in Italy, in the European countries. So they found that a helmet has a very high dead space volume, and it is an efficient alternative to face mask during CPAP, even in severe acidosis and hypercapnia. This is the first paper, 2003, can provide long duration of CPAP, but people started ignoring this type of papers. Well, this is just maybe an experiment that we have done. So helmet didn't get popular that time. But slowly and steadily, papers started coming up. For example, in immunocompromised patients or in patients of respiratory failure after abdominal surgery, in community acquired pneumonia. And even so, though CO2 washout is a problem in chronic obstructive pulmonary disease, we found papers coming out and with reasonable amount of success in all these forms of problems where NIV has been used. So these are the papers that started coming up, and but still the problems basically the key issues that are associated with the helmet were still remaining. So what is the solution to this? Well, 2015, we are not getting any solution here. So let us see if there is any solution to this or not. So the three main problems are CO2 rebreathing, noise, and asynchrony. So how can we solve the problem of CO2 rebreathing in the case of a helmet? So as there is internal volume is very much raised, there is some amount of sound behind. If somebody can stop the
Yeah,
mic,
please mute everybody.
can Can somebody mute, please?
Yeah, yeah, please, I'll just.
All right. Thank you so much. So there is internal volume is huge amount of internal volume is there. So here we see that what we can do, we can increase the fresh gas flow. Normally, remember whenever we are using helmet, we should be using two tubes. It is not a single tube ventilation. That is, we cannot use helmet with the help of a BiPAP machine. It is better to use with the help of a ventilator. Select the pressure support and the PEEP mode, and increase the fresh gas flow. Increase the flow of the through the ventilator to at least more than 50 liters per minute. If you are using certain ventilators like Avia, you can see that you can change the bias flow of the ventilator. There are many ventilators where bias flow inside the ventilator is already fixed. But there are certain ventilators where the bias flow can be changed. These ventilators are ideal for helmet ventilation. And if you can increase the bias flow to more than 10 liters per minute, normally it is around 4 liters per minute. So that also helps in giving extra amount of flow inside the helmet. If you don't have that bias flow, there are different ports inside the helmet through which you can add the additional flow, and you can give a more flow of around 10 liters per minute to the patient. If you can do this, and if you can put you can see the PCO2 or the ETCO2 basically inside the helmet, you put it inside the helmet, the ETCO2 probe is just above the cushion above the helmet, and it should be less than 5 millimeter of mercury. We can do it, we cannot do it. If you don't have that probe, you may not do it, but just increase the flow, increase the bias flow. If you don't have a bias flow, give an additional flow of 10 liters through any one of the ports that are present inside the helmet, and this will solve the problem of the CO2. Regarding noise, you just can't do much of it, but the helmet is coming with the help of the with certain plugs, the ear plugs. The companies supplying the ear plug. You can only put the ear plug to the patient so that he or she doesn't get disturbed by the amount of noise that it has been created. So the noise is quite a bit high, and so that ear plugs might help sometimes. Sometimes it is not so noisy, but sometimes it's really agonizing. So the ear plugs will help to the patient. Now the main problem is the patient ventilator asynchrony. Why this asynchrony is there? Because as the space is quite large, so you have a slow pressurization time. You also have a slow depressurization time. There is inspiratory and expiratory trigger delays. And also there is asynchrony. That is the reason of this asynchrony. You have a lot of unassisted efforts and lot of auto triggering. So all these problems, usually in the initial stages when helmet was used, they started basically when they started the use of helmet, they found these problems, and helmet basically got abandoned from many ICUs because this type of asynchronies basically were making the whole procedure basically was failing. So what to do basically? So a lot of papers started coming out, and one paper came out, and this is the crux of the whole thing. So this was the Francisco Majoli's paper which came out in 2013. If we can follow this one, these 4 points, we can really use helmet properly. See, when you are using face mask, the EPAP that you are giving and the IPAP that you are giving, the EPAP when it reaches around 10, if it is through the face mask, that is the maximum amount of EPAP a patient can tolerate with the help of when you are using a face mask. So where is the end point of the EPAP in the face mask is the starting point of PEEP, or PEEP is when you give it through the ventilator, the EPAP is equal to PEEP. The starting point of EPAP or PEEP is 10. So the end point of EPAP or PEEP in the face mask is the starting point of ventilation in the helmet with a PEEP of 10. That will basically expand the helmet. There is a cushion inside the helmet which basically seals the helmet properly, and that should be kept at a rate of 120 to 150 centimeter of water. It is very easy to calculate it. Many of us we inflate with the help of we see our pressure of the cuff pressures. The cuff pressure monitor can be used to inflate the cushion, and it can be seen through it. And you should even low resistance circuit. Basically, how can I make my circuit low resistance? Just decrease the length of the circuit. They were saying you have to decrease it up to 65 centimeter. Practically, it is impossible. You cannot decrease a 120 centimeter circuit to half of it and ventilate a patient with the help of a ventilator. It comes maximum up to 80 centimeters. And if you keep it around 80 centimeters, then you find the resistance is drastically decreased, and that helps in making this helmet successful. And you keep a fast rise time. If your helmet, if your ventilator has a rise time, you keep it fast, or you keep the decelerating type of flow. If you get a decelerating type of flow, it gives the rise time is very fast. Many a ventilator, you can set the decelerating flows, initial deceleration maybe 0.1 second, 0.2 seconds, 0.3 seconds. Keep it as low as possible. Maybe if it 0.05 seconds, that is best, or it is 0.1 second, that is the best one. So if you can keep a high peak, if you inflate your cushion properly, you could keep a low resistance circuit, keep a fast rise time, and keep your IPAP or pressure support. Pressure. Remember, when you are using a PEEP pressure support board in the helmet, PEEP is the EPAP and IPAP is pressure support plus PEEP. So if you keep a pressure support of 15, that means you are giving an IPAP of 10 and a PEEP of 10. That means your EPAP is 10 and your IPAP is 10 plus pressure support 15, that is 25. So you should keep a pressure support of at least 15 to 20 and a PEEP of 10 in these type of patients, and inflate your cushion, use a low resistance circuit, and use a fast rise time. I am telling this repeatedly because this is the crux of using a proper way to make your helmet successful. And the moment you do that, if you see the two figures, you will find the initial figure, there is a disparity between the dotted lines and the straight lines. The moment you do all these things, these two lines, that means there is a this completely aligned the complete alignment of the patients of all the situations, like the pressurization rate, which was very slow, it increases. The depressurization rate also becomes fast. The total helmet minute ventilation, it may increase, it will increase, leaks will decrease, inspiratory delays will be decreased, unassisted efforts drastically decreases, and auto triggering also decreases, though it was the statistically might not be very significant, but see, from 4 it has become 2. So that is the percentage has decreased. So this is the situation what happens when you are using helmet with this optimal setup. And when you are using this type of optimal setups, see how the paper started changing. See this paper. It came us from BK Patel from University of Chicago, where they started helmet non-invasive ventilation in early acute respiratory distress syndrome patients. And they have to abandon the whole this whole paper because with the face mask, there's a huge increase in mortality and intubation rate. So the mortality increased, the intubation rate increased with the use of face mask because the patient were going into frequent failures with the help of face mask. Whereas the treatment with helmet and IV resulted in a significant reduction of intubation rates. And there was a significant reduction in 90-day mortality. But why this happened basically? That I was telling you that it is basically the higher PEEP inside the helmet. That is the key. In ARDS, what we need a good amount of PEEP in the patient. So if I get a good amount of PEEP, the alveoli will expand. In a face mask, if you are applying a PEEP of 10, the patient is not going to tolerate it. So if the patient is not going to tolerate it, your face mask fails. Your whole NIV fails. Whereas here, it starts with a PEEP of 10. So you're giving a good amount of PEEP in the helmet, you can increase to 12, 15. So in these type of patients where ARDS is there, early ARDS is there, where you're using an IV, use a helmet and see how the difference is there. We are using it regularly, you can find those differences. So the main reason of endotracheal tube intubation in helmet was neurologic failure and not respiratory failure, which was the main reason in face mask. So that was the reason of success with the helmet. If you use it properly, and this type of papers came up, and this is one of the meta-analysis that is I am showing you of 11 studies that came up in 2016. Though the primary outcome, there was decrease in mortality, intubation rate, and complications. There was decrease in mortality in hypoxemic acute respiratory failures, not in hypercapnic failures. And the secondary outcome was decrease in ICU stay was there significantly with that of helmet. There is no difference, however, in gas exchange. But see the boxed one. NIV with face mask, there was 24 to 64% had to change face mask. The most common reason was non-adaptation to the mask, and the most common reason was the shape of the face. So it is the shape of the face of different persons, different shape, and we have a single sized mask. So that doesn't fit into all the faces. And that was the reason of the failure. So this is one of the meta-analysis that came up. And that what is more encouraging, this is the study that was seen in 2020. See the spread of, of the aerosol sprayed with helmet. Aerosol spray, see the last line, the air NIV via helmet with a tight air cushion with the IPAP of 20 and an IPAP of 10, there was negligible air dispersion. But if you don't use a cushion also, it was only 27 centimeters compared to that of the face mask 92 centimeters. That means if the person, healthcare worker is standing within 3 feet of the patient with a face mask, he or she will become infected. Whereas with the helmet, along with the cushion is well fitted, there is no air dispersion. More or less negligible chance of getting infected from a patient, whether it's a COVID patient or any other patients like the H1N1 patients. Use a helmet with a cushion inflated. There is negligible air dispersion. This is the one of the biggest advantages that helmet is having over the face mask. That is our health. We always ignore our health. So that should not be ignored. So this was the Hennywood trial. I congratulated him personally because it is very difficult to take out this type of papers during the COVID-19 situation. And they did a multi-center trial of 4 ICUs in 109 patients. And this primary outcome was number of days free of respiratory support within 28 days after the enrollment. Obviously, we didn't find any difference out here. But see the secondary outcome. Rate of intubation significantly lower in the helmet group, and number of days free of invasive mechanical ventilation was significantly higher in the helmet group. What Dr. Patel showed from Chicago, the same thing has been echoed by the Enivo trial. So this is basically the importance of helmet. We can incorporate it into our practice, and if we incorporate it, we can find patients like this who are on helmet, and the patient will be so comfortable. Patients, this is a patient of acute cardiogenic pulmonary edema. Put on, see, see the settings out here. We are giving a 55 liters of flow, PEEP of 10, a delta P, that is pressure support of 15, that means IPAP of around 10 plus 15, 25 out here. And the patient is absolutely comfortable. There's no problem with the patient. Don't go by the figures, don't go by the readings of the figures because they will be wrong. They can't interpret it properly. See the patient, how comfortable the patient is. The patient is talking, trying to talk also. There's no problem with the patient. So communicating so well with the patient. And you can see a saturation of 100% out here, if you can see. So this is one of my patients. There is numerous of those. I thought I should show you one video. Now there are different types of helmets also are coming out. One of them is known as the Venti helmet. So see this, I'm showing you a Venti helmet. In this Venti helmet, what happens basically, the patient, this is done by one of my residents. He is now in Paras, Patna. He's already joined, I think, today in this seminar. He is already there. If I'm not wrong, yes, Dr. Sahazada is there. He must be seeing, he must be cherishing those days when he was using this helmet here. And this is known as a Venti helmet. And let me share, just wait. Yeah. Here we are not using any machine or any ventilator with the patient or a BiPAP machine. There are 2 prongs which is coming from the outlet, oxygen outlet, and we are giving a very high flow here, around 30 liters of flow to the patient. This is Dr. Sehzad's voice that you can hear. Now, so this is basically a patient who was there. We are giving a high flow nasal cannula. It is basically akin to high flow, but we are giving a flow two flows around 10 liters to 12 liters from one prong and 10 to 12 liters from another source. So we are giving around 24 liters to 30 liters of flow to the patient, and this huge flow is basically making this helmet extend, basically inflated. Just see the inflation of the patient. You have a PEEP valve. You can see on the other side. Here we are using we have a PEEP valve here. We can adjust our PEEP with the help of this, and you can you can give a higher PEEP to the patient. So he's talking with the patient. Such a this after 1 hour of this ventilation, the patient is so comfortable, and the patient can talk. The patient is comfortable. Patient is moving the hands. Our residents are talking with the patients. So this type of atmosphere is created, and the whole situation becomes so jolly, and the patient becomes comes out of this situation, of that life-threatening situation, so quickly. So the practical tips that I want to give you is reassure your patient first. That is so important. Use the proper size of the helmet. How to use the proper size? The helmet comes, you can measure the neck, because there is a neck measurement collar that comes along with the helmet. You can measure the neck, and you can use the size accordingly. So there are different sizes, and according color coding is there, and you can select the proper helmet for the for a particular size of the width that is the circumference of the neck. Use ventilator and not BiPAP machine. This is so important. Use high flow, at least more than 50 liters per minute. You can use bacterial and viral filters in inspiratory and expiratory limb. Select the pressure support and the PEEP mode. Keep the PEEP more than 10, pressure support more than 12 to 15 centimeter of water. Keep the inspiratory trigger as low as possible, whether it's 2 liters. Don't keep it around 1, because if you keep the trigger 1 or zero point 0.5, there will be auto triggering. Keep it around 2 liters per minute. Keep a fast rise time that I told you, maybe 0.05 seconds, that is 50 milliseconds. Keep the expiratory sensitivity to around 30 to 50%. The expiratory sensitivity means the time when the patient moves from inspiration to expiration. That is the flow. When the flow decreases to 30%, the patient will move to expiration. When the flow decreases to 50%, that 50%, the patient goes to expiration. So if your patient is a COPD patient, keep this expiratory sensitivity high, because we need a more expiratory time rather than the inspiratory time. So we keep the expiratory sensitivity high to around 50%. This is the general rule. Even when you're ventilating a patient in a pressure support mode, keep the expiratory sensitivity higher side than around 50% in a patient who is either on mechanical ventilation or on NIV. It doesn't matter. Remember, you can see the expression of the patient. If you keep the expiratory sensitivity around 20%, you will see that the pseudomastoids are working more. The patient becomes restless. Moment you increase the expiratory sensitivity to 50, everything becomes cool and calm. So you have to be by the side of the patient to see the expression of the patient and find out whether the patient is comfortable with the treatment that you are giving or not. You decrease the circuit length to 65 centimeter and inflate the cushion of the helmet to 120 to 150 centimeter of water. If you can follow these practical tips, I think helmet is at all can be used very usefully in patients. Now, just completing this one, I just want to what to add one thing to this. We are coming up with a new, the machine is being launched. Just I am coming from one of the discussions today. Ecor machine is going to be launched in India. It will come along with that, with the of a CRRT machine. So once Ecor comes, that is the extra amount of carbon dioxide which is not being possible by the NIV, when we are using NIV to take it out, that can easily be taken out if I combine these two, ECOR and the NIV. The success rate of COPD patients will reach sky high. I have used ECOR in our COPD patients, and I have found a reasonable amount of success. And I've also used helmet in those patients along with ECOR. And the so these are the different type of experiments and new things that are coming up in intensive care. I will stop here. I more or less 40 minutes I'm speaking. I'll stop here. I have told everything more or less about helmet, and will very happy if you interact and ask your questions to me. This is the AVIA ventilator that you can see in the backdrop. This is the ventilator where the bias flow can be changed. And thank you so much for your patient hearing. Thank you.
Thank you, Dr. Chatterjee, sir. So please
Thank
share screen. And dear colleagues, if you have any questions, please put up your questions.
you. So you see, we have many people joining here, Tapas. I don't know whether you are seeing the participants list or not.
No, I
Maybe
get the list. There's a very big number, and this on
no,
YouTube.
not about the numbers. I am seeing the senior persons joining out here.
That
I
is
am seeing
because of
somebody.
your popularity, sir. That is
It's
because
not
of your
no. But I
popularity.
want something from them also. I can see Pragya from Odisha, Asif
Yeah,
joining from Kolkata. I can see Sanawaz, one of my residents joining. Sazada joining from Patna. Doctor Muhammad Mustafizur Rahman Akash. He's joined from Bangladesh, and so Mona Lisa has joined from Odisha, from Bhubaneswar. Sharbili Sinha is already there. So it's
so
really Akash
Odisha's maximum representative, Odisha's maximum representative from your followers.
maximum
Shalini
representative.
Malika.
And I am honored to get a international faculty out here in the form of Dr. Akash Muhammad Mustafizur Rahman. Dr. Akash, how are you?
Fine, sir. Thank you so much for sending me link. I am very appreciated, and thank you so much for nice presentation.
All right. Any comments? Dr. Tapesh will be asking you if you have any comments. Dr. Tapesh is basically a very big person out here in Delhi, in Gurgaon. He's a very known intensivist. He's very young actually. Don't go by the suit that he's wearing. He's otherwise normally in his jeans and t-shirt, but today he's wearing much in a formal dress, and he's a young and very agile intensivist out here. He's basically his endeavor to do this type of programs. Yes. Any questions if you have? Asif, how are you? You've joined from your car, so that's really an honor. That's really an honor. Yes.
Yeah. No, actually, I'm coming from hospital after giving evening round.
Okay. Okay. So thank you so much. Thank you, Pragyan. Thank you, Mona Lisa. If you have any questions, you can ask Mona Lisa. If you have used it in UK, you have worked in UK for long. So if you have anything to, if you have used it, you can tell your experience. Or Akash, if you have anything to tell anybody.
Thank you for sending the invite, sir. I immediately joined as I saw that you are going to give a talk on helmet.
I sent it in the last moment and you have joined. That's really an honor. Yes.
Sir, I did use it
Sir,
in UK for
those
3
patient are
years.
chance to those patient are chance to aspiration. That patient, it is suitable for or not.
Yes, better than that of a face mask. In face mask, you have a more chance of aspiration. In helmet, you have a less chance of aspiration. In face mask, you can't cough, you can't swallow properly. Everything. It's a very scary situation. I always tell people use it on yourself and you will understand. Unfortunately or fortunately, I'm a patient of obstructive sleep apnea. So I'm using this mask. I abandoned it. It's very difficult to use. I have to go to a nasal prong for that. A different nasal, these are nasal pillows that come up. They're very comfortable. So it's very difficult to use a face mask even in obstructive sleep apnea patients. So better that we use. The cost is a bit a factor, but I tell you, those patients who are COPD patients, if he can buy a helmet, keep it with him or her, wash it properly. Many a times they get admitted in the hospital in 3 or 6 months' time. It can be easily repeated on them. There is no problem. It costs you around 15,000 rupees in India, 15 to 20,000.
Thank you so much.
We can make it available in Bangladesh if you want.
Sir,
Inshallah, sir.
we have less experience in regarding this actually. How frequently change or one helmet can last for how long actually, these patients?
So actually, if you are using it on a single patient, you use it as long as you want. But you
Long means,
cannot, for
long
example,
means how long, sir, actually?
if you want to continue the NIB for 5 days, continue it for 5 days. There is no problem. As just a face mask. But you cannot use it in a different patient. I cannot say it publicly here to say it a different patient, but we Indians, we know that how to do the jugars, and Don't have to explain it to you. You are very intelligent enough to understand how to utilize your resources properly. That is a bit of diplomatic way of speaking to it. Yeah.
So during COVID time, we did use helmet NIV in Manchester a lot. And
Yes.
what we were finding is that when we were using face mask, no, patients were getting very restless. There was poor tolerability. There is facial, pressure points and all.
Yes.
So the compliance was not so good. So when we switched to NIV, we realized that the treatment failure and the rate of intubation was less, at least ours as a single center, what we saw, because we could use the helmet for a longer period of time without
Yeah.
giving much breaks. And the patient liked it, as you said. So because of that, the de-recruitment was also less and the tolerance was better, sir.
Yes. So you used it, and you used it mainly in COVID patients.
Yes,
And
sir. We did use
did you
it.
find any difference, as they say, that there is, though we can't know actually who is getting infected or not, but did you think that this helmet might have caused some amount of difference in the COVID case in spreading?
In the rate of, like in terms of getting
Exactly.
intubated
In terms of the spread of infection, because
so
here
we
the
had,
spread is much less.
So we had side room, sir, where we used helmet. So there was nobody there in that room except the nurse who was wearing full PPE with her own, fit tested mask. So
Okay.
I can't comment on that because we had individual side room for the patient who were on helmet NIV, because
Okay.
all the intubated patients were kept in one bay. And all these aerosol generating techniques like HFNC and NIVs, patients were given side room, sir. So.
All right. Okay.
So any questions from anybody, sir? Any specific questions? Okay, sir, Dr. Chatterjee, sir, one question from my side, I think, before we close it. You have significant experience with this. Now, where are you using helmet and where are you using, NIV with the face mask in patients with ARDS or hypoxemic failure? I mean,
See,
experience.
when I told you that if I get a patient of acute cardiogenic pulmonary edema, for example, where I'm using only CPAP, so where the carbon dioxide removal, still CO2 washout is a big problem with the helmet. Whatever flow I give, I might find sometimes in the patients with the COPD, very high CO2, it is a very drowsy patient. That time I'll not use the helmet. Maybe I'll try with the face mask, CO2 from the patient, and then I can try a helmet, maybe in the initial stages. But otherwise, if you use it properly, you can use it in both the situations, in acute COPD patients also, in your cardiogenic pulmonary edema also. There is no problem. In ARDS, yes, in the early ARDS, we are not using face mask nowadays. I'm using helmet. After the study that came out from B.K. Patel, have stopped face mask in this study. If I have the helmet with me, that obviously the resource should be there. Sometimes we don't have it, so you have no other choice but to use face mask.
Okay, sir. Nice. So I think there are no more questions. Any questions from anybody?
Yes, sir. So where to get the helmet from in India now, sir? Like how to?
It is available. It is available. It is being supplied from one of the suppliers in Delhi. If you want, I can give you the number.
And the cost of it is.
The cost of it, if you directly buy from the supplier, you get a bit less, around 10,000-12,000 rupees. But if you get it through another person, then obviously the cost increases 15,000-20,000 rupees. And I think the face mask, a good face mask, cost you around 5,000. This cost you around 12,000. So I think not much of a difference.
It is worth.
Yes.
Thank you, sir.
Thank you. I found Shanko has also joined from Siliguri, but I think somehow he is not there in the screen. So if there is no more questions, can we round it up out here, Tapish?
Yeah, sure. Thank you, Dr. Chatterjee. Great, lovely session and lovely interaction with everybody. Thank you, everybody, or everybody from everybody. So this will be up on our YouTube
Thank you so
channel.
much.
It'll be up on our YouTube channel. We have regular sessions there. So you are welcome to join again. Thank you, everybody. Thank you very much.
Thank you so much. Thank you for a lovely evening. Thank you.
Thank you so much. We'll meet very soon in Madhya Pradesh.
Yes, let us go and meet everyone in the Indore, and welcome to you all. Welcome.
Okay, thank you.
Bye.
Thank you, sir. Thank you.
Thank you.
Good night, sir. Good night.